When we talk about their disease to patients, we do pay attention on the clinical signs and symptoms that are actually kind of a prognostic factor for disease progression. This means a patient who has the diagnosis already should know that any kind of change in not only in the back but also in the peripheral joints, this means the knee, the hips, the heel, but also the shoulder and the elbow, are important parts of the disease, and they do have also a prognostic role in what will happen to the spine. So overall, what we communicate with them is that any kind of change that might be unusual should be reported to the physician, because this might also mean an adaptation or even an escalation of their treatment to any kind of additional treatment or any next treatment they would need. We started using biologics about 20 years ago, and until then we only had what we call the conventional treatment. This means anti-inflammatory pills that were good in effect, but they were not so well tolerated when they were taken in higher doses. They were not allowed to be taken for a longer time because not only the stomach problems but also the kidney and the liver problems would have been there. And most importantly, they would not change the course of the disease. This means the radiographic progressions that these patients have, it would not be changed. Now with biologics, we have a very fast response in a very safe way of treating patients. It is very convenient because the patients do not need to take the drugs every day. And we also have a very positive effect also on the radiographic progression, which at the end means less stiffness and much better quality of life. When we talk about early treatment, we really talk about the initiation of the symptoms. So we do not base, as it was done years ago, we do not base our decision on early or late just on the radiographs. Once the patient has symptoms, which are typically inflammatory, especially in the back, but also in the larger joints, and these symptoms are confirming the diagnosis, for example, by doing either imaging or laboratory tests, this is for us the early symptom initiation. What we are really very much into is to see and diagnose patients as early as possible. This means after symptoms for the first time occur, in order to be able to get them into early treatment. I'm not talking only about biologics, I'm not talking about only non-steroidal anti-inflammatory drugs. I talk about the general anti-inflammatory treatment overall. And this means that the earlier the patient gets the right treatment, and there is very good data to support this scientifically, the much better this patient will also do many years thereafter. We have data up to 8 to 10 years that show that indeed these patients who are being treated early are in clinical remission. This means the disease just does not progress at all, even 8 to 10 years later. Well, first of all, we cannot say that there is a late or early treatment only. I would say that at any point in time where a patient can be diagnosed and can be treated, this is the right time. Simply because we cannot turn back time. We know that even in patients with advanced, progressed disease, the treatment that we have will help. They may not help as good as if this diagnosis would have been done earlier, much earlier, but still we have a great efficacy, and we would not differentiate the early from the late treatment in terms of who to give and who to not give a drug. So we are very much in favor of treating holistically, with treating a patient as good as it gets, independent of the stage, but of course the earlier treatment is the better. We believe very much in patients' associations, in patients' self-management and self-assessment, and we also believe very much that the patients can drive their disease activity. So together with the physician, once we educate the patients what to do, what not to do, what to avoid, this means how to identify early symptoms and also how to help the physician get on the right track for the symptoms, then the better this is both for the patient and of course for the physician who is satisfied with the treatment. So the patient's opinion is a very important part of the treatment decision. And we do try to take as much time as possible. Of course, there is differences between times and times, but as much time as possible to listen to the patient's symptoms and drive and guide the treatment based on exactly those symptoms, which may, of course, vary from time to time and from clinical visit to clinical visit. We know that imaging is a very important part of the diagnosis, and we also need to show to the patients on the MRI, on the X-ray, what their problem is. So I think it's an excellent opportunity by using imaging to exactly demonstrate black on white to the patient what the symptoms are, where the lesions are, where the damage is that we are going to be treating. So overall, the patients do not need to read the MRIs themselves, obviously, or to read the X-rays themselves, but they need to see on these images what the problem is, and by that I believe that it's also much more convincing that there is inflammatory activity that needs to be treated, and that's also what we're doing with our patients, at least in the very beginning of the disease. What we do not do so frequently, and I still believe that there is no good data to do that, is to monitor the disease by imaging. This means we do not do additional MRIs, we do not do additional X-rays once the treatment has started when the patient is doing well, because we assume that the inflammatory activity will decrease. Nevertheless, at the very beginning, it's important to understand how much of inflammation, how much of structural damage the patient has, and the patient, of course, needs to see their own data, their own images, to understand what exactly their problem is. Well, I believe that remission is something that is absolutely achievable. The problem is how much of the expectation that we have may be for a single patient case there. This means we know very well that starting treatment early in younger ages or directly after diagnosis, remission is much more possible, possible with higher probability as compared if we treat and start treatment later. Nevertheless, remission is something that we do achieve. We achieve it in a large proportion of patients. At least every third patient will reach that very soon, and even more later on. And indeed, it is a possible target. Remember, remission means that the disease, not only one time point where the patient is doing well, it means that the disease is not progressing, and that's the most important key, because the patients that we have obviously need to be treated for many, many years, even for lifelong. So yes, it is a possible target, and we need to start as early as possible to treat patients in order to reach remission as early as possible as well. My hope for patients with AS is very simple, that we diagnose early. Once we diagnose early, this means we have educated both patients but also physicians to identify the treatment, the disease early. Then we can also treat early. So my hope is that there will be a point where we, after initiation of treatment very soon, diagnose the patients, and thereafter things can really go very well. Thank you very much.